Hello, I'm Karen Reckamp, Professor of Medicine and Division Director for Medical Oncology at Cedars-Sinai in Los Angeles. I'll be talking about management of non-small cell lung cancer with EGFR mutations with the latest updates. So as we know, lung cancer is not one disease, but many diseases. And though we used to think of lung cancer as non-small cell versus small cell, moving on to our histologic breakdowns and then to molecular breakdowns and PD-L1 expression, we know that each of the molecular changes that occur changes the biology and changes the treatment for lung cancer. The oncogenic drivers are shown here. EGFR is by far the most common, and in a mixed Western population, we see about 15 to 20% EGFR mutations. In an Asian population, this can be up to 50% of patients with EGFR mutations. The best data we have for first-line treatment for EGFR mutated non-small cell lung cancer is with osimertinib. And in the FLORA study, we learned that osimertinib was improved progression-free survival over erlotinib or gefitinib and had a benefit in overall survival, though modest and not statistically significant. But the progression-free survival may be different based on the mutation. As we see here, a longer progression-free survival with exon 19 deletions and a shorter progression-free survival with EGFR L858R. So this may change how we think about treating these patients. So moving forward, one of the biggest studies this year was FLORA-2. And this was a phase 3 randomized study looking at patients with exon 19 and L858R mutations, and they received osimertinib with chemotherapy versus osimertinib alone. And the primary endpoint was progression-free survival. Secondary endpoints looked at overall survival, response rates, and quality of life and safety. As we see here below, we had an improvement in progression-free survival for patients who received osimertinib and platinum pemetrexed chemotherapy, about 25 months versus 16 months on osimertinib alone. For those who, in the blinded independent cohort, there was also an improvement in progression-free survival with the chemotherapy about 29 months versus about 19 months with osimertinib alone. So significant improvement with the addition of chemotherapy. We're always concerned about our patients with brain metastases. So we see here too, from the FLORA-2 study, the PFS with CNS metastases. On the left-hand side, we see those who had CNS metastases at baseline and an improvement with the osimertinib and chemotherapy. Those who did not have CNS metastases at baseline on the right-hand side, we see an improvement, though not as striking as we see with the patients with brain metastases at baseline.
Any explanations that you've heard about why there might be a difference with CNS? Could it just be like a statistical thing, or is there some biology behind it?
Well, we do know that pemetrexed-based chemotherapy does enter the brain and can cause tumor responses in the brain in EGFR patients. So this may be a synergistic property where we're getting more benefit within the brain, but I think it is biology driven.
Interesting. Please continue.
So as we might expect, when we add chemotherapy to osimertinib, we have more toxicity. And so here we see increased cytopenias, some increase in grade 3 and grade 4 toxicities, especially with the cytopenias. And then when they looked at interstitial lung disease, they did not see a difference between the groups in interstitial lung disease. Additional data looking at the risk of CNS progression was also presented, and what we see here is, again, in the light blue, we see the chemo plus osimertinib, and those lines all show a longer time to CNS progression, also and non-CNS progression, and very few deaths in both arms, but also longer time to death. So the red arms are those with osimertinib monotherapy, and the CNS progression and non-CNS progression were both higher. We see on the right-hand side some evidence of CNS responses in those patients. So moving on to other potential options, we had the Mariposa study that was presented at ESMO this year. And this is a phase 3 study, again, in the frontline setting for patients with EGFR exon 19 deletions or L858R. And patients received a three-way randomization to amivantamab and lazertinib, osimertinib, or lazertinib to look at the contribution of components. The primary endpoint, again, being progression-free survival, and then also looking at overall survival, response rates, and safety. And we also see here an improvement in progression-free survival with a combination of amivantamab and lazertinib over osimertinib, and we see about 24 months versus about 16 months with a hazard ratio of 0.7. Again, when we want to look at brain metastases, here on the left-hand side, history of brain metastases, still an improvement with amivantamab and lazertinib, about 18 months versus 13 months, and those without brain metastases also had significant benefit. Again, when we're adding medications to EGFR TKIs, so lazertinib is a third-generation EGFR TKI, very similar to osimertinib. When we add amivantamab, the EGFR MET monoclonal antibody, we do see an increase in EGFR-type toxicities with rash, paronychia, diarrhea, all increasing and somewhat increased in the higher grade toxicities. So on the left-hand side, you see the combination, and the right-hand side is osimertinib alone. The ILD in this group was low and similar in both arms. So thinking about frontline therapy, we now have multiple options. It's going to be important to understand how to select patients for these options, but you can see over on the left-hand side, we have FLAURA monotherapy, osimertinib that is very well tolerated, the combination with chemotherapy from FLAURA2, increasing the progression-free survival to 25.5 months, and then Mariposa adding amivantamab to a third-generation EGFR TKI lazertinib, increasing progression-free survival to about 24 months. We know that the combinations are causing increased toxicity, so selecting patients will be important. The patients with brain metastases may benefit from additional therapy up front, potentially those with higher disease burden, potentially those with L858R mutations, as we know they don't do as well on osimertinib alone, and then also looking into options of following ctDNA and tumors that continue to shed.
Any sort of clinical observations in terms of side effects and quality of life, osimertinib plus chemo versus ami laser?
I think the timing is a little too early. We're starting to potentially use these combinations, but they all have different toxicities. I think the other challenge is that you're putting a patient on infusions, and with osimertinib and chemotherapy, it's every 3 weeks. With amivantamab, it's every 2 weeks after they get their loading doses. So obviously, the rash and diarrhea become significant when you're combining two EGFR agents with amivantamab, and then the cytopenias and fatigue will be an issue with chemotherapy. So I think these are big considerations for our patients, and still the majority of patients at this time, I think, benefit from osimertinib and do very well on osimertinib.
Okay, please continue.
So moving on to the setting of resistance. So this year we had the Mariposa 2 trial. Again, looking at patients with documented EGFR exon 19 or exon 21 L858R mutations. These patients had progressed on osimertinib as monotherapy or as the most recent line of therapy. They had to have stable brain metastases to enter into the trial, and they were randomized to amivantamab, lazertinib, and chemotherapy, or chemotherapy alone versus amivantamab and chemotherapy. And again, the primary outcome was progression-free survival, and they looked at the two arms versus chemotherapy separately. Here we see the results, and we see here in the purple the amivantamab lazertinib chemotherapy. In the green color, we see amivantamab chemotherapy, and in the gray, chemotherapy alone. So we saw improvements in progression-free survival with both the amivantamab lazertinib chemotherapy and the amivantamab chemotherapy. And very similar median progression-free survival, 6.3 months versus 4.2 and 8.3 with the three-agent combination with amivantamab and lazertinib. Overall, the hazard ratios 0.48, 0.44, and significant benefit for these patients. Again, looking at intracranial progression-free survival, here we see benefit for patients who received the amivantamab with lazertinib and chemotherapy, and those who received the amivantamab and chemotherapy, and very similar for both. And I think this was a surprising result for us, as we assumed that the third generation TKI would add some benefit in the CNS. But here, for patients who had had progression on osimertinib, we see similar benefits. And again, this may be a component of chemotherapy synergizing with the amivantamab to have improved intracranial benefit. And again, the toxicity profile, here we see in the gray on the left-hand side, chemotherapy alone, amivantamab and chemotherapy in the middle, and in the green on the right-hand side, the combination of amivantamab and lazertinib and chemotherapy. We see some increase in cytopenias. For the patients who received amivantamab, lazertinib, and chemotherapy, there were higher rates of all toxicities and potentially grade 3 toxicities. Looking at the bottom row, we saw AEs that were of special interest, and again, rash, slightly higher, grade 3, with the lazertinib and amivantamab combined with chemotherapy. But the interesting toxicity we also see is venothromboembolism, and that was higher in the combination group. ILD similar in the two groups, but higher than chemotherapy. And based on that toxicity, what is really moving forward is the amivantamab chemotherapy combination with similar clinical benefit and activity, but less toxicity. So in the second line setting, I think we're really going to be looking at the amivantamab and chemotherapy, not adding the lazertinib in this setting.
Just kind of curious, like, roughly how many times have you used amivantamab?
So I have been a part of the clinical trials using amivantamab, so I've had some experience over the past several years using the drug, and we have started to use it for some of our patients as it's become a little more available with this data. So we've used it with the amivantamab. You do get the infusion-related reactions in a large proportion of patients, and most patients. We do a lot of education of our patients and our staff to help them understand that these infusion-related reactions are expected. And they have a very good protocol for the way that the dosing is given. Usually by the day 2 infusion, the infusion-related reactions do not recur. So that's very manageable. The toxicity of rash can be challenging, and patients need a lot of prophylaxis, education, and a lot of care of their skin and the rashes that develop.
Interesting. Please continue.
So moving on to other interesting agents in the resistance setting for EGFR mutant non-small cell lung cancer, we have patritumab deruxtecan. And the HERTHENA Lung 01 study was presented and published this year. And what we saw with this, this is a antibody drug conjugate with a HER3 antibody and deruxtecan linker. And in this study, we see progression-free survival in the 5.5 month range with duration of responses about 6 months. And we see over on the right-hand side response rate in about the 30% range. So this is showing activity. What is very small at the bottom is that this is across multiple types of resistance mechanisms and mutations, and the responses occur across all of these. This was not dependent on HER3 expression, and so no expression is required for the patritumab deruxtecan. Again, where we are very interested in these patients, where we see a lot of the progression occur is in the brain and in the CNS. In the Herthena Lung 01 study, there was a second report that showed, again, improved time to CNS progression. And you see this here in those patients with a history of brain metastases. The green line is those with CNS disease, and some prolongation of time without CNS progression. And even with those without a history of brain metastases, as you see, those who develop brain metastases, a very, very low number with that green line at the bottom. Here's just another image of patients with response in the brain. And again, this is a antibody drug conjugate. We don't always expect these drugs to go to the brain, but yet there are these reports of responses and even complete responses in a subset of these patients. So moving down to more non-targeted therapies for patients with EGFR mutation upon resistance. Again, the line of ADCs, this is looking at the Tropion Lung 01 study, and this is datopatamab deruxtecan, a TROP2 antibody linked again to the deruxtecan. And this is showing all comers for patients who had on the left-hand side, with and without genomic alterations, and we saw an improvement in the progression-free survival over docetaxel. This was more pronounced in those patients with non-squamous non-small cell lung cancer. So based on this, there have been some interest in looking at patients with actionable genomic alterations, or AGAs. So moving forward, there's a trial that the Tropion Lung 05, so the datopotamab deruxtecan, who in patients with actionable genomic alterations. And so this is an ongoing study, again, presented at ESMO by Dr. Pazarez, and they're looking at the treatment in those patients with alterations. As you see on the bottom there, more than 50% of these patients have EGFR mutations. So it will be highly relevant to patients with EGFR mutations. Early data, again, showing response rates in about 35% of all treated and over 40% in those with EGFR mutations. Duration of response, 7 months, and median progression-free survival, 5.8 months. On the right-hand side, you see the waterfall plot and the percent change on the bottom. So we see these responses and treatments that have activity in patients with EGFR mutation following significant number of prior therapies. The safety profile is shown here. Again, nausea, the stomatitis with the TROP2 inhibitors can be an issue. GI constipation, decreased appetite, nausea, vomiting, rash, and cough, very minimal. So overall tolerated, and the mucositis and stomatitis is a known toxicity of this agent that is manageable and does require some, again, patient education and potentially some prophylaxis. So thinking about subsequent therapies for patients who have received frontline osimertinib or combinations with third-generation EGFR TKIs who then develop resistance, which are most of our patients, we really are excited to see some emerging options with response rates and some options that are not your typical targeted therapies that cover multiple mutations and mechanisms of resistance. So chemotherapy with amivantamab improved overall survival over chemotherapy alone and had less toxicity than the chemotherapy with amivantamab and lazertinib. We saw CNS benefit in this group, and this may be an option for our patients in the future. Patritumab deruxtecan also improved responses and had a 5.5-month progression-free survival in heavily pretreated patients and had about a 30% complete responses in the brain. Datopotamab deruxtecan, early efficacy in patients with actionable genomic alterations, and response rates in EGFR mutant non-small cell lung cancer in the 40% range. All of these combinations and treatments have very differing toxicities and mechanisms of actions. So we need to consider that as we're thinking about what the subsequent lines of therapy that we're introducing to our patients. And we need to consider the potential for sequencing these therapies. And so patients may be able to receive more than one because we do not have overlapping mechanisms of action, and resistance mechanisms may be very different across these agents. So I think it's an exciting time in this area of resistance in non-small cell lung cancer.
Before you go on, I was going to ask you about another paper that we found that you did, specifically focused on the management of infusion reactions related to amivantamab in the journal Lung Cancer. Was there anything in that study that you might want to comment on? There were some pretty cool graphics there about the timing and all. Anything about that paper, particularly that you think would be worth bringing up? It was such a practical, important point.
I agree. The infusion reactions, as we discussed with amivantamab, are relatively common, and the majority of patients will have an infusion-related reaction. So early intervention with steroids and emergency medications, when it occurs, we can often slow down the rate and resume on that day one. And again, even when they can't resume on day one, the second day they often do get the infusion. And by the week 2 infusion of the loading doses, I haven't seen any further infusion-related reactions. So it is very common and it is very treatable. And I think that that's the biggest message. And with education of both the patients and the staff, it's a relatively manageable side effect.
All right, please continue.
Moving on to exon 20 EGFR mutations, we now have new data and new therapy for the frontline for patients with exon 20 EGFR mutations. And the Papillon trial was presented this year, again at ESMO, and published in the New England Journal of Medicine. These were treatment-naive patients with documented exon 20 insertion mutations. And these patients received amivantamab with chemotherapy versus chemotherapy alone. And again, progression-free survival was the primary endpoint, also looking at response rates, duration of response, overall survival, and safety. So here we see the bottom line. Patients who received amivantamab and chemotherapy had improved progression-free survival over chemotherapy alone. And we're looking at 11 months versus 6.7 months with a highly significant hazard ratio below 0.4, so significant benefit in this population. There's an interim overall survival, as we see here, very too early to determine, but we do see a slight benefit toward overall survival improvement with the combination up front. And thinking about the safety profile, so we've seen the combination of chemotherapy and amivantamab, and with the amivantamab, with the EGFR and MET combination, we do see EGFR type toxicities, paronychia, rash, dermatitis, stomatitis, diarrhea. We also see the MET type of toxicities with hypoalbuminemia and peripheral edema. But the grade 3 were quite low for these patients. And then the cytopenias, as expected, potentially slightly higher grade greater than 3 neutropenia in these patients. But overall, reasonably tolerated and manageable. And pneumonitis, again, was reported, but low percentage, about 3% in patients. So again, amivantamab remains the targeted option for exon 20 non-small cell lung cancer, and frontline amivantamab with chemotherapy can improve progression-free survival over chemotherapy with a trend toward improved overall survival. We are still looking for novel drugs for these patients with improved therapeutic window, and we need drugs with improved CNS activity, and the work in this area is still in its infancy, and we look forward to seeing what comes next.
Generally speaking, right now, outside a clinical trial, what is first-line therapy likely to be in the hands of a clinical investigator like yourself?
So we're moving toward amivantamab and chemotherapy for these patients, and again, it takes a little bit of working with the toxicities. And cytopenias are a little bit higher with the combination, but patients are tolerating it, and again, it's early days, but we're seeing good responses. So I think it's easy to move this to the front line. We still would like to see more, targeted TKIs and things like that that have a good efficacy and safety profile mixed together. We don't have that yet.
But in general, do you think most investigators, NCCN, et cetera, are they blessing chemo plus AMI?
I think this is moving forward. Yes, I do think this is moving forward because these patients have limited options and don't necessarily do very well with therapies. So seeing this improvement in progression-free survival, I think makes it an easy choice.
Great. Please continue.
So now that we've covered advanced stage disease, we're always excited to move these targeted agents into the earlier course of disease. And so we had the approval of osimertinib in the adjuvant setting back in December of 2020. And we'll be talking about osimertinib and potentially in the locally advanced stages also. So ADORA was the phase 3 study that, again, looked at patients who had surgically resected non-small cell lung cancer, stage 1B through 3A, and these were tumors greater than 4 centimeters or with lymph node involvement. And patients went on to receive chemotherapy as required by or necessary by the treating investigator, followed by randomization to osimertinib versus placebo. And this was a unique treatment duration of 3 years in these patients, and the primary outcome was disease-free survival and secondary outcomes of overall survival. So at ASCO this year, we learned that osimertinib can improve overall survival in our patients with resected EGFR mutant non-small cell lung cancer, which is an exciting time. So here looking at stage 2 and stage 3A, where we generally see a more significant benefit, it's about 5 years. The 5-year benefit's about 12%, but a hazard ratio of 0.49. And when you add the stage 1B to this, on the right-hand side, we still have a hazard ratio of 0.49 and about 10% benefit at 5 years. And this is still pretty early. There are very few deaths that have occurred. We wait for further maturity, but we still see a benefit in this overall survival. And again, looking across stages 1B alone, here we see 94% versus 88%, stage 2 alone, 85 versus 78, and then stage 3, where we often see the highest benefit, and we have 85% versus 67%. And again, event levels are still very low for death, and you see the forest plot here on the right-hand side. Toxicity. So we do see obviously toxicities with osimertinib over placebo, and generally the grade 3 and higher, less than 25%, less than 1% leading to death. About 13% had discontinuation, another 12% with dose reduction, and about 30% with interruptions. But overall, reasonably well tolerated, and 11% greater than grade 3 toxicities with the osimertinib, and very few serious AEs, 3%. And here we see another paper that was published this past year and by Dr. John, looking at tolerability and health-related quality of life. So we see here adverse events, osimertinib in the blue versus placebo in the yellow, and we do see more adverse events, but tend to be not a significant percentage of patients. And looking here, those with the quality of life did not change significantly. Quality of life was maintained with the osimertinib and really close to the baseline. And here we see on the right-hand side those with dose discontinuation, interruption, and reductions, and overall well tolerated, and patients able to continue on therapy for the most part. So based on this, we still have a lot of questions in the adjuvant setting. We're looking at perioperative targeted therapy as we see benefits in the immunotherapy arena. Will perioperative neoadjuvant therapy be better? What's the optimal duration of therapy? Is it 3 years? Is it longer? Is chemotherapy necessary? And we'll hear that from Dr. Gaynor with the ALINA trial, where they omitted chemotherapy in the ALK population. What's the best timing for this TKI therapy? Do they need it prior to surgery? Do they need it just adjuvant, or do they need both? There is a study ongoing for stage 1A disease. And so those early stage, we may have some data to support the use in earlier stage disease. And again, this was for a study for deletion 19 in L858R, but would this be also beneficial for patients with other EGFR mutations? And then, can we detect minimal residual disease? Can we intensify patients therapy for patients who don't need it, and intensify for patients who may need it, adding chemotherapy as such, like we may do in the metastatic setting? And then, what are the mechanisms of resistance? Are they going to be different? And what are the best therapies following resistance?
I wanted to ask you a little bit about dose reduction of osimertinib. Again, I saw a paper you did, I think it was in the advanced disease setting, but just sort of globally, what do we know about the relationship between dose reduction and activity? It sounded like maybe there could be a correlation, but what's the bottom line?
I think that overall there may be a little higher activity with the higher dose, but for patients who can't tolerate the higher dose, obviously being on the drug is better than being off or having to take multiple breaks of the drug. And so I think overall being on the lower dose is beneficial, but we have seen those step up in patients, especially with brain metastases and things like that, that we do see potential even overcoming progression in patients who go up on the dose. And so I do think dosing is important, but obviously staying on the drug is also important, and some of our patients really cannot tolerate the highest dose of drug.
All right, please continue.
So I'll end with the LAURA study as a preview to ASCO this year. So this is consolidation osimertinib in unresectable stage 3 non-small cell lung cancer. And we see, again, these are patients with standard exon 19 and L858R mutations. They received concurrent or sequential chemoradiation. And then they went on to receive osimertinib versus placebo. And again, these patients did not receive consolidation immunotherapy. This is not a patient population where we think immunotherapy is necessarily beneficial. And so they went on to just receive the osimertinib or placebo. And we know now, and the overall progression-free survival is the primary endpoint. We know now from a press release that this did demonstrate a efficacy benefit for patients in this setting. To note, these patients received ongoing osimertinib. There wasn't a time point. There wasn't an endpoint of 2 years or 3 years with osimertinib. So this was ongoing osimertinib following chemoradiation. But we do see a progression-free survival benefit, and this will be presented at the plenary session at ASCO this year. So again, we have a very exciting time for EGFR mutant non-small cell lung cancer. The treatment landscape is evolving quickly. We have more options for patients in the frontline therapy that improve efficacy, again, with chemotherapy or the combination of amivantamab and chemotherapy. The paradigm for subsequent therapy after resistance is also shifting, and have, again, multiple options that show responses and potential benefit with amivantamab and chemotherapy, patritumab deruxtecan, and potentially datopotamab deruxtecan, again, all with differing mechanisms of action and potential for sequencing in our patients. In the adjuvant setting, osimertinib makes a lot of sense. We now have overall survival benefit for these patients, and really should be used in most patients who fit those criteria. Consolidation osimertinib, improving progression-free survival, is also an exciting outcome to await to see the full results at ASCO this year, and we'll be discussing that presentation and the implications for our patients. Biomarker testing, again, highly important. And now we see it should be done in the perioperative setting. We need to know these, at least EGFR mutation and likely ALK alterations very early on in the setting so that we can send them down the right pathway, because immunotherapy will not be the right pathway for our EGFR patients. And looking at these biomarkers and finding biomarkers for selection for resistance is also going to be important, and for early detection.